Assessment is a process where the practitioner evaluates the playing field to develop a game plan. We already have some definition of the playing field because we studied anatomy and massage. This is like the housekeeper saying, I know what a house looks like, I just need to figure out what's necessary to clean this house. Or your mechanic saying, I know how to fix cars, I just need to figure out what needs to be assessed to fix this car. There are different forms of assessment, and this presentation is not about assessment techniques. It's more about figuring out how assessment fits into the framework of a session. There are two types of assessment, subjective and objective. Let's start with subjective. Subjective assessment is where the client expresses what they think and how they feel about their condition. One of my favorite scenes from The Big Bang Theory is where Sheldon takes Penny to the emergency room, and when they ask what the problem is, he says there's a lack of adhesive ducts because she slipped in the tub. These clients are particularly interesting to deal with because they come in and they say, I have a problem with my psoas, and I've got this short leg, and my piriformis isn't right, and okay, problem is you have pain in your back, or you've got some limited range of motion, or your yoga performance is not what you'd like it to be. Sometimes those people are interested in simply improving the body that they live in, and so they'd like to know that they've got a short psoas or some limited range of motion so that they could work on that. In most cases, however, I look for a specific, that they're able to express that I don't have the range of motion in my yoga practice, or my low back hurts when I get up in the morning. This is one of the beautiful things, by the way, about trigger point assessment. The most useful thing I find in trigger point manuals is how well they've matched the activity to the trigger point. For instance, if I reach out with my shoulder to lock the car door and it hurts, that tends to be middle deltoid. If I reach back to tuck in my shirt and my shoulder hurts, as well as having some weakness in my grip, that tends to be infraspinatus. If, however, I reach back to tuck in my shirt and it also hurts when I'm throwing a ball, that tends to be coracobrachialis. And so this part of trigger point assessment is actually very useful for helping you to understand what the problem is. I've included those sort of details in posts out there. We'll talk about that more when we get to the examples. Subjective assessment also helps us to find undetectable factors like some medications that might be affecting their muscular activity, or the activity of onset, or infections or surgeries, or in this case, the ideas of other practitioners, where other practitioners have thought it's this, and they've either succeeded and the client would like more of that sort of work, or they didn't succeed and the client would like you to do something different. Subjective assessment takes goals, it makes them better defined, and it offers some direction for objective assessment. It also indicates ancillary components. In the case of the golfer who had the shoulder problem, it was interesting that at a point he said, about a month before I developed this shoulder problem, I got hit in the head, and he pointed right to the place where the cranial governor is for that shoulder. Usually it's not that clear. Usually you have to do some evaluation of the hip or upper cervical or cranium in order to find the associated governors. This process also often clarifies goals. Sometimes in this process, as they're describing the problem, they'll describe additional symptoms that they'd also like to have taken care of, or may even change the focus of their goals. In objective assessment, the practitioner evaluates the tangible condition of the client and matches it to the subjective assessment. This is more physical in nature. Here we're looking at assessment techniques like range of motion or palpation, those sort of things. As we go through and find those things, it helps the client to understand the plan and helps them to manage their expectations. Now, they begin to connect their complaint to something physical that's happening that helps them to understand why I might be working in this area. In craniostructural work, for instance, I may do some testing of their legs to see the strength in their adductors, abductors, etc., evaluate the associated parts of the cranium, change the cranium, and then go back and reassess the legs. This helps people to understand that the work that I'm doing on the cranium is directly connected to what's happening with their legs. It's very useful during this process if the client can recreate the pain. If they can recreate the pain, then I will test again after my treatment to see if they can create that pain again. One of the other nice things that comes out of objective assessment is an understanding of how this is differentiated from similar patterns. For instance, in the ankle problem, in our example, there are several muscles that create pain in that area, and objective assessment helps us to single out what's happening, whether or not that's peroneus longus or peroneus tertius or something that's happening in the foot, etc. Sometimes objective assessment modifies the goals and indicates a larger problem and helps us to refer this client to a more appropriate practitioner. After assessment, the practitioner should have pinpointed the symptomatic muscle and evaluate the associated governors. Let's go back to our example and fill out the integrative sequencing worksheet. First, let's look at peroneus longus. We established in the goals that they have a painful, unstable ankle. Next, we should go through the proper subjective and objective assessment to determine that it really is the peroneus longus and not one of the muscles that produce similar patterns. We know that this trigger point is predicated on local joints, and so the next piece is to evaluate the fibular head. From there, we want to make sure that we've taken care of any nerve pressure, and so we evaluate the L5-S1 nerves, which means we need to really look at L5, the sacrum, and some of the soft tissues around the top foramen of the sacrum. There's not something in the pectoral girdle that we really need to look at here. Next, if it's in your skill set, you want to look at pelvic balancing and evaluate whether or not that pelvic is posteriorly sheared and needs to be brought anterior. We would want to balance the upper cervicals. Lastly, if you have craniostructural training, we want to look at the lateral strain pattern of the SBS. Now let's go on to infraspinatus. We've established that they have a painful shoulder when sleeping, or problem when golfing, or problem with pain along the scapula when they're reaching. Next, we want to take a little bit of time to go through those shoulder muscles and establish that it really is infraspinatus. We should evaluate the humeral head to see if it's anterior. Look at C4 through C6 to see if there's any nerve pressure there. Next, we want to look at these other shoulder joints. The acromioclavicular joint and the sternoclavicular joint can affect those rotator cuff muscles and how they behave. I don't look at pelvic balancing when I do this, but I know that there are many therapists who believe that any shoulder work should be preceded by balancing the pelvis. Next, we want to look at upper cervical again. The atlas tends to be anterior and have moved laterally away from the trigger point. Lastly, if it's in your skill set and you do craniostructural work, you'd want to look at the coronal suture. There are a few other pieces here that are involved. That anterior atlas is often connected to a superior vertical strain pattern that needs to be corrected, but most directly, we would find that this work along the coronal suture is really where we can release those rotator cuff muscles. Again, we've just started from the complaint and worked our way through from the complaint to the trigger point, to the local joints, to where there might be nerve pressure, to the pectoral girdle, to the pelvic girdle, to the upper cervical, to the cranial. Many therapists don't have pelvic balancing or upper cervical skills or craniostructural skills, and so if they're not in your skill set, you can still work the local muscle in those joints and get longer lasting results. Let's move on.